Hello, and thanks for listening to the MiCare Champion Cast. I'm your host, Brian Peters, CEO of the Michigan Health and Hospital Association, and I'm incredibly honored today to welcome a very special guest, someone who has been a friend, a colleague, and in fact, a mentor of mine for many years. Rick Pollack is the president and CEO of the American Hospital Association. The AHA has nearly 5,000 members, and as such, it's the nation's largest hospital and health system membership organization. Under Rick's leadership, they have become one of the most respected and effective advocacy organizations in the nation. Beyond his strong advocacy leadership, Rick has also been instrumental in addressing historic workforce challenges, expanding healthcare access, improving healthcare quality and safety, eliminating disparities, and much, much more. In today's episode, we'll learn about Rick's journey to the AHA and what healthcare priorities are top of mind at the federal level as the 2024 presidential election rapidly approaches. Rick, welcome to the show, and thank you so much for being with us.
Brian, thanks for having me. I really appreciate it, and I also appreciate the long-standing partnership that AHA has had with the Michigan Hospital Association over the years. And you have been a great colleague and a great leader and a good friend. And everybody should know that you're now a member of the AHA Board of Trustees. So Michigan provides us with a lot of great leadership, not only you, but of course our chair-elect in Tina Fries-Decker. And, the other thing that we have in common, I think, is that, MHA, because of Michigan being this kind of state it is a microcosm of what we deal with across the country. I mean, you face a lot of the same challenges as we do, and our constituencies have the same diversity that we experience both in Michigan and across the nation.
Well, I absolutely agree, Rick, and we'll get into some of those issues here on the show today. But I really appreciate the great opportunity to serve on the AHA board. It's a tremendous honor. And as you said, with Tina Fries-Decker, the Corewell Health CEO, set to become AHA board chair, really looking forward to her great leadership as well. So, Rick, as I mentioned, we have been friends for many years, and I've really admired as I've watched your trajectory and your great leadership there at AHA. But for our audience, it would be great to start by having you share with us just a little bit about your background and your journey, how you came into the role that you now occupy at the AHA.
Sure. I always had an interest in government and politics, and, that was my, area of major in college. And I went to the State University of New York. And that's a system that's kind of different from a lot of other state systems. I mean, you have great ones in Michigan. In SUNY, we had 4 university centers, Binghamton, Albany, Stony Brook, and Buffalo, and then 8 4-year arts and science colleges, of which I went to one of them, the one in Cortland, New York, and then, 2 medical schools, 2 law schools, a lot of community colleges, and other types of, educational pieces. So we never really had a flagship, but they did have this thing called the Washington Semester Program, and they selected political science majors from several of the campuses to be in that, and that gave me an opportunity to come to Washington. It also gave me the opportunity to intern in Congressman Dave Obey's office from Wisconsin. And at the time, they were very, very careful about who you can intern for. They wanted you to be in offices that had a track record of providing a substantive experience as opposed to running Xerox machines and running errands. So it was kind of limited, but I wanted to work for someone that was younger, and at the time he was one of the younger members of Congress. He was in his early 30s. He ended up serving 40 years in the Congress and became chairman of the House Appropriations Committee. And so he hired me after I had been an intern, and went to grad school at night at American University. Actually met my wife in his office. We only overlapped for 2 weeks, but I guess that was enough, and she stayed there for another 8 years, so we became part of the family. But I left to become a lobbyist for the American Nurses Association for a couple of years, and then came to the AHA first as a frontline lobbyist, then as the vice president for legislation, and then for about 24 years, the executive vice president for our overall advocacy operation, and then for the last 10 years, president and CEO of the organization. And Brian, one of the things I tell people is I never took a course in healthcare.
Isn't that something? I think you've done quite well, and you've learned as much about healthcare as anyone in the country, Rick. Just hearing you in so many different settings over, the decades, your grasp and understanding of all things healthcare is truly impressive. But I appreciate you sharing that background. We really want to lift up healthcare as a career path for young people today. In fact, we have some efforts underway here in Michigan. I know many of our State Hospital Association colleagues, and certainly you at the AHA, do as well. So I think anytime we can talk about those various paths, and there are so many different ways to contribute in healthcare, and certainly those of us in the association realm have a very important role to play. Well, Rick, you've been at this for some time. What are some of the most fundamental shifts that you've seen in the national healthcare environment during your time at AHA? How are we different today than we were back when you started, and where do you think we're going from here?
Well, in terms of the fundamental shifts, there are many. First, of course, at the national level, the political polarization that we have today was
Right.
nothing even close to what existed when I first started, and meaning to navigate that cross current of all the partisanship. That's a lot different than it used to be. Healthcare policy has become pretty much budget driven. And it wasn't always that way, but that is a characteristic of a shift over time. Most recently, the shift in the last, 15, 20 years has been really away from, since the enactment of the Affordable Care Act, which is now almost 15 years old, believe it or not, it's shifted away from focusing on large reforms and vision type of things to transactional things. Under Presidents Clinton, to a lesser degree Bush, but certainly under Obama, there was a big focus on reform and where we want to go in healthcare in the future. Now it's all transactional. And the ACA really changed the dynamics in terms of how health policy works. It's really now basically a foundation or a framework to work off of. Notwithstanding some rhetoric about repeal and replace in this current election season, that's just not really on the table. And I think that really that framework is the one that we're going to continue to build on. And you think about Medicare and Medicaid that was enacted in 1965, how many times have we amended those programs over the time? I think it's the same thing now with the ACA. The other shift that I've seen is the way advocacy has changed and how AHA has approached and evolved. And I think this probably is similar to what you've done in Michigan. It's hard to be bipartisan, no question about it, and you always need to fashion your issues in a bipartisan manner. And we can go through so many different issues, but we always try to shape it in a bipartisan manner. But the other thing that has changed is the levers of influence. In the advocacy business, it's all about trying to influence people. And in terms of lobbying, the basics remain the same in terms of relationships. But what has really changed a lot is the media cycle is no longer a media cycle, it's 24/7.
Right.
We rely much more than on just relationships. There are multiple levers of influence, whether it's grassroots or grass tops, whether it's building coalitions. Data is always important. Framing issues in this soundbite environment takes a lot more care and testing than it ever did before. Advertising was something we didn't do when I first came to AHA. Now it's a lever of influence. Convening events in different forums is a way to exert influence. And then, self-regulation is a concept that we've used where when we see there's a legitimate issue, and we're concerned that the policy process or the political process could take us in a bad direction, trying to do things on our own to address issues, whether it's health disparities, whether it's billing and collections, whether it's stewardship guidelines for 340B. All of these approaches that I just outlined are things that have evolved over the years, and we didn't do a lot of that when I first came.
Well, I think that's a really helpful overview of how things have changed. I'd be interested in your thoughts as well, Rick, on this integration trend. And I reflect on 30 years ago when I was new at MHA, we didn't have any multi-state health systems with a presence in Michigan. We didn't have any investor-owned systems in our state at that time. And virtually every hospital was a freestanding independent. And of course, that's changed very dramatically. You've seen that, of course, across the country. So any thoughts about how that has changed the dynamic for organizations like ours, for associations that are in the advocacy and representation business?
Well, one of the most significant changes, and it's integration beyond just multi-hospital systems. It's really our systems coming together and doing things across the whole healthcare continuum. And that's where it's really changed from a policy perspective, because now we just can't pay attention only to inpatient. It's now, of course, outpatient, always has been, but more so than ever before, when half of all surgeries are done on an outpatient basis. But physician payment is something that now we have to pay a lot of attention to, since we employ our in alliances with so many physician organizations or groups, home health care, post-acute care. As systems come together, they broaden their involvement across the continuum, which means we need to be more engaged on those kinds of issues. That's where it's changed considerably.
Well, that's a great point. And here in Michigan, we project that about 80% of all physicians who are still in active practice today are employed by our member hospitals and health systems. Absolutely, to your point. Well, Rick, we've talked a little bit at the 30,000-foot level. Let's get just a bit more granular now and talk about some of the issues that are top of mind for the American Hospital Association. What are the issues that you and your team are focused on right now?
Well, let me put it in the perspective of the calendar, because a lot of what drives what we need to be focused on is a function of the congressional calendar or the regulatory agenda. So right now, when Congress comes back next week, they have essentially 1 month before the start of the fiscal year to fund the government. And I suspect that they'll do something that is, kicks the can down the road to a lame duck session of Congress after the election. And then that's where the action begins, because there are a lot of issues that will have to be dealt with before the end of the year. And if they don't deal with them, bad things will happen. Not only will the government shut down, but there are several issues that are very important to us beyond that. So for instance, Medicaid DSH, that's an $8 billion item. There are $8 billion worth of cuts that would kick in at the end of the year in Medicaid DSH unless we stop them. We've sort of had temporary patches along this year. We need to at least get a 2-year moratorium on those cuts. Those cuts were part of the ACA. They were intended to be something that could have been cuts that may have been logical if we had anything close to universal coverage, but we never really hit that. So that's why those cuts need to be stopped. Medicare physician payment, per our previous conversation, on January 1st, there's a big cut to Medicare physician payment, and that needs to be stopped. So those are two things that are in the funding bucket that need to be dealt with before the end of the year. The second set of things that need to be dealt with before the end of the year are extensions of current law that expire. So in the rural arena, the low volume adjustment for rural hospitals, the Medicare dependent hospital for rural hospitals, they're two somewhat lifelines for our members in those areas. They expire at the end of the year, they need to be extended. And then waivers that we were able to achieve during COVID that really were reflective of innovation, hospital at home and telehealth. All of those COVID waivers in those areas expire at the end of the year, and they need to be extended. And then the last piece is that in this lame duck package, these are our issues. There are other things that will get thrown in there that cost money, as well as these extensions, I might add. And one of the ways that people will potentially look to pay for these items is site neutral. That is eliminating the hospital differential for hospital outpatient departments that receive a higher amount of payment as compared to ambulatory surgery centers and imaging centers and other types of entities that are providing services outside of hospitals. And that's a fight that we've been involved in many years now. That will be something that we need to prevent from happening before the end of the year as part of one of these packages.
Well, we've been proud to be your partner on the site-neutral payment battle for some time now. Rick, for our listeners, what's the elevator pitch on site-neutral payment? When the AHA advocacy team talks with key lawmakers on this issue, which, on the surface sounds like one of those easy fixes, the right thing to do, but of course, when you peel back the layers of the onion, it's not quite so simple. But what's really the elevator pitch on
Yeah, the
on this
elevator
issue?
pitch is there's nothing neutral about site neutral, right?
Right.
Because we do get a differential and we think we deserve it. We deserve it because, number one, we take care of everybody that walks through our doors. Those other non-hospital connected outpatient facilities, they don't take Medicaid, they don't take poor people, they're not open 24/7. We find that the people we take care of in OPDs are different than what those organizations take care of, because the people are sicker, they're often poorer, they often have experienced more recent hospital readmissions, and we've done studies to show that. The other thing to keep in mind is that when people say, let's pay let's get rid of that differential because hospitals are overpaid in the outpatient department. We're already underpaid in the outpatient department, both for physician and facility services. So the notion that we're being overpaid is ridiculous when, we're getting paid less than the cost of services. It just pushes it down further. That's about as quick an elevator pitch as I can give.
Nothing neutral about site neutral. That's very well said. So Rick, as we're talking about advocacy, one thing that's really impressed me about your leadership, and I'm talking about, the last 10 years as you've been the CEO at AHA, but even the years prior to that when, as you said, you were the executive vice president leading all of the advocacy operation for AHA, is the fact that you're not only involved in the halls of Congress, in other words, dealing with legislation that we either support or oppose, but I've really observed that AHA has strengthened under your leadership the engagement in the courts and also in the regulatory arena and the things that come out of the White House, the things that come out of CMS that have nothing or have at least little to nothing to do with decision-making that happens in Congress. And so I think there have been some real wins, particularly in the courts, and I'm thinking about 340B as one example. Can you reflect a little bit on the thinking there and how AHA has really focused in a very holistic way in your advocacy?
Yeah, when we talk about advocacy and representation, we often just kind of think about what goes on on Capitol Hill or in your state legislature. But as you say, it's broader than that. It's dealing with the regulatory agencies. It's dealing with independent commissions. It's dealing with how you work with the media to shape the story. It's dealing with academic groups. So it is, as you suggest, it's much broader than that. And the courts, litigation has been a tool that we have had to employ on various occasions more recently than not. And, we've always been involved in litigation, but it's been more so in the political environment we're in, where they're unable to legislate on a lot of matters because of the gridlock. And that forces the executive agency to be more aggressive in doing things. And as a result, you have to litigate because they're pushing something through because they couldn't get it through the political process. And if we have a difference, it can't be dealt with other than through litigation. And that certainly was the case with 340B. It was the case with the online tracking situation that we ran into. It was the case with a variety of other issues that are out there. And of course, 340B isn't going away. And that's still tied up in various ways in different courts in the issue of contract pharmacies. So yeah, litigation has become a tool. And in light of the Chevron decision, which the Supreme Court said is that no longer will we give deference to the agency in interpretation of laws, it opens up other opportunities to more broadly litigate when we have a concern. Now, we didn't when it came to Chevron, we were agnostic on it because there are times where we would rather work things out with the agency as opposed to having it in the courts. But given where we've ended up, it's a new tool that can be used in a broader way.
Absolutely. I appreciate that insight. And as you know, Rick, the Michigan Health and Hospital Association has been a proud partner with AHA as an amicus party in some of this litigation at the federal level that you referenced. So, Rick, let's talk a bit about rural. We happen to have a current board chair of the Michigan Health and Hospital Association, Dr. Julie Yarrow from ProMedica, who comes from a rural hospital and really has been a passionate advocate for rural challenges. And in fact, she's been involved in some committees there at the AHA as well. What are some of the unique challenges that AHA is confronting when it comes to your rural membership? We mentioned one of those, obviously, is 340B, but what else can you describe for our audience on the rural side?
Obviously, as we talked before, for the lame duck session, getting those two extensions on low volume adjustment and Medicare dependent hospital adjustment through is important. But the big challenge that our rural hospitals face is the fact that they often don't have the volume to support the overall infrastructure that they try to provide in terms of the range of community services, because sometimes the volume isn't there, and that is a constant challenge. And then, of course, workforce issues are more difficult in rural areas in terms of attracting people. Behavioral health care is more challenging. Again, it goes back to the workforce because there is a shortage in general, and those shortages are exacerbated when it comes to our rural communities. But the other part of it is, put aside the challenges for a second, there are some serious opportunities for our rural members. Because if you think about the fact that so much of the healthcare dollar and the demand for service in the near future is going to be around managing chronic conditions of a large piece of the baby boom population, of which I'm a part. People don't need to go to other areas to get those services. Chronic care management is something that can be done at home, and people don't want to have to leave their community if they're suffering from certain types of conditions that can easily be managed at home. The other opportunity for rural hospitals has to do with convenience. Patients want convenience, and rural hospitals are situated in a manner in which they are able to provide care in a much more convenient way. And I think that we have to keep an eye on the opportunities as well as the challenges. Over the years, we have tried to address the rural challenges through a whole series of payment adjustments. And when you think about it, it's a credit to the Congress and our mutual champions that we have worked with over the years. I mean, you have rural referral centers, you have sole community providers, you have the two types of adjustments I mentioned before. You've got, floors for the wage index. You have the critical access hospital designation. We have the rural emergency hospital designation. It's not as if we haven't put in place a series of these adjustments, if you will, but it still remains a challenge because of the issues that I mentioned before. And of course, the other challenge that we find is in maternal health and OBGYN access. And a lot of that goes back to the issue of workforce and volume. And I think that what we try to do, as an association, and I think you do as well, is, we want to provide every one of our members the opportunity to be an access point for healthcare in their community. It may not be that everybody can do everything for everybody, but being an access point to be a player in service to the community as part of a network of caring is what we have to strive for. And that's what we're working toward.
Well, I just want our listeners to understand that the American Hospital Association has been such a powerful advocate when it comes to rural health and such a strong partner to us. And I really want to give you credit for that, Rick, and your great leadership. Let's shift gears a bit. This is obviously an election year, and for advocacy organizations like the AHA and the MHA, particularly when it's a presidential election year, we are paying very close attention. So now with the primaries in the rearview mirror, in the conventions in the rearview mirror, what are you looking for over the course of the next couple of months, Rick, as Election Day approaches? And then, of course, we have a lame duck session, as you mentioned, quick on the heels of that election. But what's top of mind for you with the election?
Well, we're a bipartisan organization, as we talked before, so we don't get involved on either side in the presidential elections. We always just work to be a resource to the candidates on both sides and make sure that they have the information they need in terms of data and what our positions are. When it comes to the Congress, of course, we're much more involved through our political action committees and much more engaged in that regard. But one of the things that we have to look for when it comes to presidential elections in particular is to always remember that people make policy. And it's really who are the people that are going to be surrounding the folks that are coming in, because the president is not going to be involved, for whoever the president is, in the nitty-gritty policy issues. It'll be up to the people. So that's something we always want to keep an eye on. I think the thing that's interesting about this presidential election year is that healthcare really is not a big issue when you think about it. The real big healthcare issues are really around women's reproductive services and the issue of prescription drug prices. That's what is really the big issue that's out there. We're really not talking about where we should go as a country in terms of the future of healthcare or what we think the system ought to look like. That's really not the focus of attention. As I said earlier, it's a little transactional when you get down to it. Now, always in the background is the issue of affordability. That's the soundtrack for any political campaign, because healthcare, people are concerned about affordability. But I think the affordability focus has largely been on the issue of drugs more than anything else, and to some degree out-of-pocket costs. The out-of-pocket costs that are growing, the root cause of which is skinny health plans, non-compliant ACA health plans, and high deductible health plans where, people are just more exposed than ever before. If you look at a potential Harris administration, I think it'll continue to build on the Affordable Care Act. And the real focus next year will be on the subsidies that expire in the ACA that were enhanced during the COVID era. And that's like a $360 billion item that needs to be extended next year. And that's something that obviously a Harris administration will be vocal advocates for. I think they'll be focused on expanding their efforts that they've already put in place with regard to prescription drugs. And if folks have been looking at the media, the issue of medical debt, I think this is going to be an issue that comes up. It was not only an issue with regard to Vice President Harris, who took an interest in it, but it's also been an interest for the vice presidential candidate in his personal biography in terms of Governor Walz. And, there are things that we don't have a problem with in terms of dealing with the issue, in terms of not having credit reports reflect medical debt. But the real issue is one I mentioned before. What's the reason for medical debt? It's those high deductible insurance programs, those skimpy insurance programs that put people more at risk. Under a Trump administration, I think we'll see pressure on Medicaid, particularly around moving toward block grants. Again, I don't think you'll see repeal and replace as a theme, notwithstanding some earlier comments, but they're not going to be vocal advocates for the ACA as it relates to the subsidies, and they will be reluctant to sort of use that as sort of the platform. But they will also focus on prescription drugs. I remember when President Trump ran the first time, he said that the drug companies were getting away with murder. And he did put out a pretty aggressive drug plan. So I think they'll continue to focus on that. The last comment I would make is that regardless of the election, and this is probably, I think, the most important point, regardless of the election, there are certain issues that are just not going to go away that we will be in the middle of, whether it's deficit reduction and the HI trust fund, whether it's site neutral, whether it's 340B, whether it is concerns about consolidation. Value-based payment, by the way, is a bipartisan issue that both administrations have embraced over the past 8 years. Insurer accountability, that's become a bipartisan issue that we welcome. So there are a lot of these issues that regardless of who gets elected, they're going to be out there, we're going to be in the middle of them, and we're going to have to deal with it.
Absolutely, Rick. And I think transparency is another one of those bipartisan issues where certainly we've seen a lot of interest from both sides of the political aisle. Well, last comment on the election then, and I won't ask you your prediction on the outcome other than to say, would it be your sense, as someone who lives and works there in D.C., that it's very likely that we would still have divided government after the election as we head into 2025, meaning we could have control of either the White House or the House or the Senate from one party, and maybe the other party has control of the other levers?
Well, as professional lobbyists, which both of us have been and still kind of are, regardless of being CEOs of associations, divided government is a lobbyist's dream, right? Because otherwise you don't have leverage in terms of the process. Given what's occurred over the last month in politics, I'm reluctant to make predictions about anything.
That's fair.
And when you look at it, I mean, the presidential race, so much could still happen between now and election day. And right now it looks like it's going to be close, and it's probably going to be pretty tough race. And we don't know where it's going to come. And Michigan will have a pretty big say in the outcome. In the Senate, it's probably considered to be 50-50 literally as we speak right now. With West Virginia going Republican and with the retirement of Joe Manchin and the almost certain election of their Republican governor, Jim Justice. And then the three big races everybody keeps an eye on is where there are Democratic incumbents that are at risk, is in Ohio, Sherrod Brown, in Montana with Senator John Tester. And, there are a couple of other races as well. People are keeping an eye on the open seat in Arizona. And you've got an open Senate seat that is competitive in Michigan, because everything is always competitive in Michigan, I guess, at the statewide level to some degree. So there are a bunch of those. The House conventional wisdom is that it'll flip. It's always been that way. But again, we've got a long ways to go. Here's an interesting thing. The election for president is going to be determined in 6 states, of which you are one of those states. And all the other states on a presidential level don't matter for the Electoral College. It's really those 6 states. And in some degree, it's certain counties in those 6 states. So there's a narrow playing field. In the House of Representatives, what's interesting is that of 435 seats, there are probably 24, like 24, that are in play. And most of those that are in play that could flip and determine control in the House are in New York and California. And neither of those states are in play in the presidential. So how the down ballot works and how coattails work is going to be very different this year. So I don't know how we're going to end up, but we always have to play the cards that are dealt us.
I appreciate that insight, Rick. So on that note, we have a saying here at MHA that advocacy is not a spectator sport. And whether you are a clinician at the bedside, whether you are in the C-suite and leadership, whether you're a hospital trustee, whatever the case may be, you should not hesitate to get engaged. And organizations like ours, the MHA and the AHA, we have tools and resources that can help people who are interested in getting involved. But can you talk a little bit about this issue, and how you would encourage folks in our field to get involved in advocacy, to not be intimidated by that. And maybe along with that, Rick, talk a little bit about some of the things that AHA is doing, like with the Coalition to Strengthen America's Healthcare. And I'm referencing this challenge we have collectively at the 30,000-foot level, where there are some well-motivated and well-funded actors right now across the national scene who are really advocating, contrary to the best interests, in our belief, of hospitals and our ability to provide access to care to everyone in our respective communities. And we have to answer that challenge. But can you talk a little bit about that?
Sure, and let me separate the two. First, in terms of getting involved, in terms of grassroots, you mentioned the word intimidation, and that's really key. People should not be intimidated in terms of engaging their legislators. They work for you, and you could be a resource to them. And we in hospitals are not single issues groups. We are involved in so many different issues, and you should view yourself as being a resource to them on multiple issues. And, I always used to try to explain to my kids when they were younger what a lobbyist does. And, part of it is being an educator, being an objective educator on issues where you are the expert, and they will look to you for their guidance and counsel. And as a former congressional staffer, don't forget the staff. Sometimes people say, hey, they're young and, all that, and they're not seasoned, but they are influential, and they want to be educated, and you can help educate them. So get to know the staff. Get to know the staff, position yourself as a resource on multiple issues where you can help them. And also, if you're in a district or a place where somebody has been really helpful to us, whether it's a Debbie Stabenow, who's not running for election, I'm just mentioning her because she's someone that has been a real friend. Help them politically. Be involved in their political efforts, because, it's always important to recognize our friends. On the other issue, it's a really important one, and I know it's a long story, but you're right. There are motivated adversaries that are out there that are seeking to undermine public confidence and trust in hospitals and health systems in an effort to advance their own advocacy agenda and also to advance their own position in the marketplace. So who are we talking about? We're talking about some of the commercial insurance companies, and they're the biggest proponents of site neutral. We're talking about some of the drug companies. They're the proponents of restricting the use of the 340B program, which provides discounts for drugs that our hospitals purchase. We're talking about labor unions who want to put in place rigid staffing ratios that prevent us from making reforms in how we do the work that we do in the face of the challenges that we have with regard to shortages. They're what we often refer to as the anti-hospital billionaires, like Arnold Ventures, for example, where their agenda is to apply the Medicare rate to the commercial book of business, if you will. That's why we've expanded the role of the Coalition to Strengthen America's Healthcare. We're pleased that you provided such leadership as a member of that board as well, Brian. And the purpose of that is, number one, to tell the positive hospital story. It's so important. And, the media doesn't like positive stories by and large, but we have to continue to push it out. And we work every day at AHA and MHA to just tell the story of the heroic things that our members do day in and day out in every way. The second thing that's important is to push back on the incoming from the motivated adversaries, to challenge them in terms of some of the charges that they make in their efforts to advance their agenda. And the third piece is using the coalition, which involves all the state hospital associations, all the national hospital associations, and other stakeholders, using the social media techniques. We have a community of 2.5 million people that we've recruited to help us out with Grassroots, to use our advertising tools to push back on some of the specific advocacy issues that we have in play, site neutral being one of them for this lame duck session.
Well, thank you so much, Rick. That's really good insight. Before we wrap, I wanted to touch on one last topic that I know is a real focus these days for the AHA. And we just had a retreat of our board at the Michigan Health and Hospital Association and spent a fair amount of time on this topic because it's affected hospitals and health systems right here in Michigan. And I know this is a cause for concern across the nation as well, and that's the issue of cybersecurity. And we've witnessed some pretty serious attacks on the healthcare field just in this calendar year. We know that healthcare is the number one target globally for cyber criminals. That's right from the FBI, and that's been consistent for some time. But what can you share with our listeners from the AHA perspective on this emerging threat to our field?
Well, we've seen this building up, and we've been very involved in this area. As you know, one of the first things we did is we ramped up our capability to engage. And we recruited John Ridgey, a former FBI special agent that ran the cyber division, and is on our team now as our vice president and national advisor for cybersecurity. We've done a lot of things with the FBI. Working very closely with them on a variety of matters. We have an advisory group that we work closely with them on, and we're one of several critical infrastructure elements like energy and like banking that we work with in coordination with them. And John is a real expert in this area. And just yesterday, a fellow by the name of Scott G joined us as his number two, who's a veteran of the U.S. Secret Service and also has a background in other forms of law enforcement. But the real issue that's going to be coming at us are the issue of minimum standards for cybersecurity that ought to be applied to hospitals, and that's something that we're going to have to deal with. Now, three things about that. Number one is that we help create something called cybersecurity productivity goals, and that's called CPGs. We did it with the government, and we believe that these goals and guidelines are ones that we all ought to be working to adopt. We help shape them. We don't want them to be mandated, but if they're going to do anything, it needs to be consistent with these CPGs. That's critical. The second thing that's even more critical is that whatever we do, it shouldn't just apply to hospitals and health systems, which is kind of what they keep focusing on because we're easy to get people's arms around. But look at the two most recent intrusions that turned the world upside down in our world. One was beyond our world, but the one in our world was change, Optum Change. When that went down, that affected everybody. That was a third party that wasn't buttoned down. The issue of CrowdStrike, which affected more than just hospitals, that didn't happen. That wasn't targeted at us. That was a third party. So whatever minimum standards we put in effect for cybersecurity, it has to impact everyone in the healthcare sector, not just hospitals. And then the third piece is really the financing part. This is just an added cost for us. We know we have to do what we have to do, but we have to recognize the added cost. And there needs to be assistance in that regard. We were able to work with the White House to get assistance from Microsoft and Google for our rural constituency. We want to broaden that beyond that. And then the last thing, and we've made this pretty clear to the government, as you know, most of these intrusions are really state actors or criminal gangs that are sanctioned by Russia, China, Iran, and North Korea. And while we work closely with the intelligence agencies and the law enforcement agencies, at some point the military has to be involved, and some of these other countries are going to have to pay the price for these intrusions. And that's another piece of this puzzle that needs to be a part of it, because we have great capabilities as a nation.
Well, couldn't agree more, Rick. And it's high time to root out the bad guys and really bring them to justice, because it's becoming increasingly frustrating to deal with these sorts of attacks that put human lives in jeopardy. I mean, there's just no question about that. But appreciate all that you and your team are doing at the AHA. Well, Rick, it's been an absolute pleasure having you with us today on the MiCare Champion Cast. I'm going to give you the last word if there's anything else that we haven't discussed that you'd like to share with our listenership from your perspective.
And the only thing I would share is to reiterate what I already said, which is we really appreciate your leadership. We really appreciate the partnership with the Michigan Hospital Association. And, we appreciate everything that everybody does day in and day out to take care of people back home. It's just an honor and a privilege to say that we represent hospitals and health systems.
Well, that feeling is mutual. And thank you again, Rick, for your great friendship, your great leadership, and of course, for joining us on today's broadcast. With that, I'd like to thank our listeners for tuning in and encourage those who have not done so already to subscribe to the MiCare Champion Cast. You can head to mha.org to learn more. Thank you, and we'll be back soon with another episode.